Hello guys, I'm Dr. Meenu. Welcome to the National Test and Discussion of Medico. Now, you might be wondering what this is about. Whether it is for your NEET PG exams or for your INI-CET exams, you might be studying all your theory parts now. Whatever you have studied so far, or I hope that you are up to your theory, whatever you have studied so far. But what is more important as far as these exams are concerned is that you do more and more questions, as many questions as possible. So that is what we are trying to help you out with here. These are the topics that you just cannot afford to miss. I'm not saying these are the only topics, but these are the ones that you cannot afford to miss, and you must be able to solve the questions that come from these. All right. So with that, we'll take up our first question, which is from the basics of reproduction. A 29-year-old woman has been trying to conceive for over 2 years without success. She has regular menstrual cycles and her hormonal profile is within normal limits. Her partner's semen analysis is also normal. A hysterosalpingogram shows patent fallopian tubes. During assisted reproductive technology procedures, fertilization fails to occur, even though INI-CET results in a successful embryo development. Genetic testing of the embryos shows normal chromosomal content. Which of the following is the most likely cause of her infertility? Now, you might be wondering what this has got to do in basics of reproduction. This is a question from fertility, right? But what is important is that everything in obstetrics or even in gynecology depends on the basics. All right. So if your basics are thorough, if you're thorough with your basics of reproduction, you will be able to answer questions from whether it is from fertility, whether it is from recurrent pregnancy loss, whether it is from abortion. All right. So here in this case, So we'll start with oogenesis. Oogenesis, you know that it is the process of development of a mature ovum, and it begins by the 6 to 8 weeks of intrauterine life. What is happening in oogenesis? There is an oogonium which by mitosis forms a primary oocyte. By the time of birth, all the oogonia have already been converted into the primary oocyte. Remember that there are no more mitotic divisions happening after birth. All right. Now, this primary oocyte is arrested in the diplotin stage of meiosis 1. Okay. It is arrested in the which stage? In the prophase 1 of in the diplotin stage. And this is called the dictate stage of the oocyte. So, it remains that way from birth till puberty. At puberty, meiosis 1 is completed very fast. Okay, so meiosis 1 is completed. How is it completed? Under the influence of the LH surge. So another point that you have to remember here, meiosis 1, which had been arrested in the prophase, which had been arrested in the diplotin stage of prophase 1, has immediately been completed at the onset of puberty under the influence of LH surge. So if you are asked which is the hormone dependent division in oogenesis, you have to say it is meiosis 1. So when meiosis 1 is completed, as you know, this is a reduction division. As meiosis 1 is completed, there are two things that are formed. One is a secondary oocyte, which is haploid, and the first polar body. There are two polar bodies released in oogenesis. The first one is released at the time of ovulation. Okay, I hope is this clear to you? So that has happened, and the secondary oocyte remains there and enters meiosis 2. If fertilization occurs, only if fertilization occurs, this meiosis 2 will be completed, wherein a second polar body is released. So two polar bodies are being released, the first one at the time of ovulation and the second one at the time of fertilization. All right, this is clear, no? Now, meiosis 2 also remains arrested. Where? In the metaphase stage. There also, the secondary oocyte, even though it enters meiosis 2, is arrested in the metaphase stage. Unless fertilization occurs, this division is incomplete. All right. So, now, how does fertilization occurs? For fertilization to occur, certain other processes have to happen. First one is the sperm capacitation, the capacitation of the sperm. What is it? These are the biochemical changes that enable the sperm to penetrate the oocyte. Where does this happen? This happens in the female genital tract. So sperm capacitation has to occur. Then certain enzymes have to be released which will help the sperm to digest the zona pellucida, which is the acrosome reaction. And after that only, the sperm will fuse with the oocyte and it triggers the oocyte activation. And at that point, meiosis 2 is completed and the second polar body is released. All right. So what was our question? See, only ICSI, that is intracytoplasmic sperm injection alone has resulted in a successful embryo development. So what is this due to? So this means that oocyte activation has not been completed. Okay, there is a failure of the oocyte activation and completion of the meiosis 2. That means for oocyte to be activated, there has to be a rise in the intracellular calcium, which is the ion that is responsible for oocyte activation. It is calcium. So if there is some defective oocyte factors or there is insufficient sperm-induced activation, this will not take place. What does this mean? It means that normal fertilization will fail to occur in spite of all the normal semen parameters. But what is being done in ICSI? In ICSI, a sperm is injected directly into the cytoplasm of the oocyte. So that means all these steps can be bypassed. So if ICSI is being done, then it can result in the formation of a successful oocyte. Okay. So moving on to the next question. The decidual space is obliterated by. What is decidua? You know the endometrium of the uterus. Once pregnancy occurs, the endometrium of the uterus is converted into the highly specialized endometrium of pregnancy, which is called the decidua. In the decidua, if this is the myometrium here, And then you have got the blastocyst that is implanting. You know that it is a blastocyst that implants. There you got the blastocyst. Now, here you have got the decidual space. This part here, that is the decidual space. This portion, that is the portion between the implanting blastocyst and the myometrium, this portion is called the decidua basalis. While this one, the one between the blastocyst and the uterine cavity, that is the decidual space, that portion is called the decidua capsularis. And here, the rest of the endometrium or the rest of the decidua becomes a decidua parietalis. At around 14 to 16 weeks, the decidua capsularis will fuse with the decidua parietalis. This results in the formation of a different decidua, which is called the decidua vera. When this occurs, that means the decidual space becomes obliterated. So it is from 14 to 16 weeks and the obliteration is completed by the 16th week. Okay, that is how you have arrived at your answer. There is another important point from this. This means that theoretically, twinning or multiple pregnancy is possible till 16 weeks because until then the decidual space is patent. So pregnancy can occur. It is also the same answer. All right. Moving on to the next question. It is about placenta, fetal membranes and umbilical cord. You have a 25-year-old primigravida. She is presenting to the antenatal clinic at 28 weeks of gestation. She reports no significant symptoms and has had an uncomplicated pregnancy so far. So look at that. She has got no significant symptoms and has an uncomplicated pregnancy so far. On routine ultrasound, a placental abnormality is detected. The placenta is located over the internal os, covering it completely. She is asymptomatic with no history of bleeding or pain. Her vitals are stable. What is the most appropriate management at this stage of pregnancy? A few things that you have to note here is that she has got no symptoms. She is asymptomatic. That is very important in the management of this case. Her vital signs are stable. So here, what is your management at this stage of pregnancy? Look at this. This is the placenta. Do you see this? This is the placenta. And what is marked here? This is the internal os. So, what do you understand? The placenta is completely covering the internal os. What do you call such a placenta? It is a placenta previa. Okay, so what is her period of gestation? We all know that the management of placenta previa depends on the period of gestation also. So she is at 28 weeks of gestation. What do you do here? What are the symptoms? You have said that she's asymptomatic. What are the symptoms you expect in a case of placenta previa? First one is painless bleeding PV, which is the most common symptom. There may be a warning hemorrhage or what is called a sentinel bleed. These are the symptoms that you expect. So where do you see a sentinel bleed? It is seen in a case of placenta previa. Or causeless and recurrent bleeding. What do you expect to when you examine the patient? When you examine her, you'll find that whatever symptoms she has is proportional to the amount of blood she has lost. That means if she has not bled much, her vitals will be stable. And when you are doing a per abdominal examination, you will find the uterus is corresponding or maybe a little more than the period of gestation because the placenta is lying in the lower uterine segment. The uterus will be relaxed. There won't be any contractions. It will be soft. She may not have pallor, or even if she does have pallor, it will be proportional to the amount of blood that she has lost. Okay, so you've got a non-tender uterus and sometimes you'll have a floating head. Mostly you'll have a floating head and malpresentations are also common. Why? Because the placenta is located in the lower uterine segment. And the fetal heart sound will be heard normally. Okay, so these are the things that you see in a case of placenta previa. What do we want here? What is the appropriate management step at this stage of pregnancy? An asymptomatic person presenting to you, the first scan being done at 20 weeks. It is at 20 weeks that you can say that this woman has got a low-lying placenta or a placenta previa. So you're doing a scan at 20 weeks. The 20-week scan shows that it is a low-lying placenta. What do? You repeat the scan when at 32 weeks. Here she is at 28 weeks and this is how her placenta has been located. What is it that you do? Do you do an immediate delivery? No. Why? There is no need. What you'll do is you do an expectant management with serial ultrasounds. In this case, you'll repeat the ultrasound at 32 weeks. Again, it is a placenta previa. You can repeat another one at 36 weeks. You'll confirm your placenta previa. And in the case of in this case, where there is a complete placenta previa, where the placenta is entirely covering the internal os, there is no other option but to go for a cesarean section. That is your final management. Okay, we'll come to the final management in a later question. Let us take the next question. Identify the type of placenta. I'm sure you all know this placenta. What is this? This is a circumvallate placenta. What is it that you see here? See, the chorionic plate. That is, there is a double fold of chorion and amnion. Here you've got a valve-like structure. There is a double fold of chorion and amnion. This is the circumvallate placenta. There is something else called a circummarginate placenta. This is also similar to the circumvallate placenta, but instead of the double fold of chorion and amnion, you've got a single fold where the transition between the two is smooth. In both these cases, you can expect the baby to have low birth weight. There can be FGR, there can be antepartum hemorrhage. These are the complications you expect from both circummarginate and circumvallate placentae. Look at this here. You've got several other placental variations. You've got something called a succenturiate lobe. What is it that you see? There is a smaller lobe of placenta. If the lobes are more or less the same size, you'll have a bilobed or a bipartite placenta. In both these cases, you can expect the placenta or the succenturiate lobe or the accessory lobe to be retained within the uterus if you have not identified this in a prior scan. So what happens? Let us see what happens. There is a risk of lobe detachment, definitely. Possible fetal growth restriction. More importantly, there can be a retained product of conception. That is, this succenturiate lobe or in the case of a bipartite placenta, the other lobe may be retained inside the uterus, causing postpartum hemorrhage, subinvolution of the uterus. Okay. Then we have got placenta previa, which we have discussed and we'll come to once more in a later question. Circumvallate placenta we have discussed. Then we have a velamentous insertion of the cord. What is that? Look at this. These are the blood vessels that are entering the placenta and these are the membranes. Before entering the placenta, you find that the membranes are, the blood vessels are already ramifying inside the membranes. What happens? In this case, if these blood vessels are lying over the cervix, when the cervix dilates, these blood vessels will start to bleed. This can result in a vasa previa. Okay, so vasa previa is associated with a velamentous insertion of the cord. We have got another cord insertion here. This one here, this is also attached to the side of the placenta. Normally, cord is attached to the center of the placenta like this. But here, cord is attached to the side. But in comparison to the velamentous insertion, you find that the blood vessels are not ramifying. The blood vessels are supported inside the Watten's jelly. They ramify only after reaching the placenta. This one here is called a battledore insertion of the cord. So you have to be able to identify the different placental variations and whatever complications that are associated with each of them. All right. Another thing that you have to know is about the placental tumors. These are not that important, but just in case, one thing you need to know, which is the most common placental tumor. The most common placental tumor is a chorioangioma. And the only placental tumor that can metastasize to the fetus, placental tumor, which metastasizes to the fetus, which is that? It is the melanoma. Okay, these are two things about the placental tumors that you need to know. Okay, let's go to the next question. Placental attachment disorders. Placenta, you've got three different kinds of attachment disorders, which is together called the placenta accrete spectrum or the PAS. These are the accreta, the increta, and the percreta. What are these? Placenta accreta, you've got to match the following. Basically, it is the same only. It is given correctly only. In placenta accreta, what do you see here? This is the placental bed, all right. This here being the endometrium, the myometrium and the serosa. I'll tell you an easy way to remember. If it is accreta, it means that the placenta will attach to the myometrium. In case of increta, what happens? The placenta will invade the myometrium. What about the case of percreta? In case of a percreta, you find that the placenta will penetrate the myometrium, reaching the serosa and may even invade the uterus or the bladder or the nearby structures. Look at this. How there is no more myometrium here. The placenta has attached to the myometrium, which is called the accreta. Here the placenta has invaded into the myometrium, which is called the increta. And here the placenta has totally penetrated the myometrium and has reached the serosa, which is called the placenta percreta. Alright, is this clear so far? So you can look at this. This is how it is. Now what happens here is, once the placenta has attached, you can find that if you're doing a scan, the myometrial layer is no longer there. There is an absence of the myometrial layer on the scan, which is called the Nitabux layer or the fibrinoid layer. There is a sonolucent zone behind the placenta when you're doing the scan. This will be absent in a case of a placenta accrete syndrome. Placenta accrete syndrome, it's also known as a morbidly adherent placenta. Remember that term also, a morbidly adherent placenta. What is absent? The decidua basalis is absent. Which part is absent? The part between the implanting blastocyst and the myometrium, the part between the implanting the blastocyst and the myometrium, which is called the decidua basalis. There is absence of the decidua basalis and the fibrinoid or the Nitabux layer. This is absent in a case of a placenta accrete syndrome. Okay, this is most commonly associated with the placenta previa, or if there has been a previous uterine scar as in a cesarean section or a myomectomy, whatever it is, if there has been a previous scar, there is a high chance of a placenta accrete syndrome. So what did we say? When we do a vaginal ultrasound, you can see that the subplacental sonolucent zone is absent. So you might get that in the question also. So if you have, the question mentions that a scan done shows absence of the subplacental sonolucent zone. What is this zone? This is the decidua basalis. Immediately go for a placenta accrete syndrome. This can also be diagnosed using a doppler, where you will be able to see the blood vessels that travels through. But what is the investigation of choice to identify this? It is MRI. How do you manage a case of an accrete syndrome? You'll always go for a planned cesarean section. Make sure that blood is arranged and make sure that this is taking place in a tertiary care center where you've got all facilities available. So when do you do a cesarean section? A cesarean section is done between 34 to 37 weeks depending upon the invasion. Now, if you are asked to pick a single answer, you're not given a range 34 to 37, then your best answer would be 36 weeks. Mostly you'll have to go for a cesarean hysterectomy. You may have to take out the uterus if you're not able to detach the placenta entirely, even though there are some recent advances that are coming up called the triple P procedure, where you are able to take out only that part. If there is a focally adherent placenta, you'll be able to take out only that part. So just remember that term also. It is the triple P procedure. The triple P procedure. This is also associated with placenta accrete syndrome, where what do? There is a perioperative localization of the placenta. You have to make sure that it is an accreta, that is a perioperative localization of the placenta. Then you will have to do a pelvic devascularization. And finally, if it is a focally adherent placenta, you'll be taking out only that placenta. You don't have to take out the entire placenta. And then what do? You go for a myometrial reconstruction. Okay, that is about the triple P procedure. Coming to our next question, amniotic fluid and its abnormalities. You have a 28-year-old woman. She is gravida 2, para 1, presents at 34 weeks of gestation. 34 weeks. For a routine antenatal visit, she reports no significant complaints but mentioned that her abdomen feels unusually large. On examination, her fundal height is 38 centimeters, which is greater than the gestational age. An ultrasound is performed revealing an AFI of 28 centimeters. The fetus is in cephalic presentation and there are no visible congenital anomalies. The fetal heart rate is within normal limits and the Doppler studies are unremarkable. Look at this. All you can see is fluid, right, in this ultrasound. Which of the following is the most likely underlying cause of this patient's condition? Now, first thing that we'll talk about is the measurement of the symphysiofundal height. When do you measure it? Usually we say that it is to be measured from 24 to 36 weeks. From 16 to 36 weeks, the symphysiofundal height will correspond to the period of gestation in weeks. If the symphysiofundal height is 3 centimeters or more, if the symphysiofundal height, there is a disparity of 3 centimeters or more from the gestational age, that means that this is pathological. Here what do we see? She is 34 weeks, her fundal height is 38 centimeters. That is, there is a disparity of 4 centimeters between the gestational age and the SFH. That means there is some pathology here. What are the causes for larger symphysiofundal height? First one, whether it is a larger symphysiofundal height or a lesser, the first thing that you have to remember is wrong dates. She may have given a wrong dates. Then we have got, if it is a larger one, there may be a full bladder, it may be a multiple pregnancy, there can be polyhydramnios, it may be macrosomia. You know all this, right? So there are so many reasons for a larger symphysiofundal height. Here you have got this difference, and the ultrasound is already given. They've given the AFI as 28 centimeters. What is the AFI? It is the amniotic fluid index. It is not practical to measure the amount of amniotic fluid. So what we do is we measure the amniotic fluid index, wherein you divide the abdomen into 4 quadrants, Q1 to Q4, and you measure the single vertical pocket or the deepest vertical pocket in each of the quadrants. This vertical pocket must not have cord or any fetal parts, like this. See, here they have measured Q1. This is Q1. Here they've got Q2, Q3 and Q4. Okay, and the total of these becomes the amniotic fluid index. A normal amniotic fluid can be anywhere between 8 and 20 to 25. You say that there is polyhydramnios if the AFI is more than 25 or the single deepest pocket is more than 8 centimeters. Okay, here it is 28 centimeters, so it is polyhydramnios. Next, what is the cause of polyhydramnios? The most common cause is idiopathic. If you're asked what is the most common cause of severe polyhydramnios, that is, you have got an AFI of 40, very high AFI, severe. If it is a severe polyhydramnios, what you have to immediately think of is, see, how does the amniotic fluid get reabsorbed? It is by swallowing, right? So amniotic fluid is not being swallowed, it is being produced. That is the main component of amniotic fluid is fetal urine. So the kidneys are functioning, but the gastrointestinal system, which takes up the amniotic fluid back, is not functioning, as in a case of an esophageal atresia, say. So the cause of severe polyhydramnios, the first thing that you have to remember is GIT malformations. This is followed by CNS malformations. Here it is 28 centimeters. That is not a very severe polyhydramnios. So in this case, maternal hypertension or fetal growth restriction both will not cause polyhydramnios. But both gestational diabetes and fetal esophageal atresia can cause. But in case of an esophageal atresia, the hydramnios will be very severe, which is not the case here. So here, the most likely underlying cause of this patient's condition is gestational diabetes. Okay, is this clear? What are the complications that are associated with polyhydramnios? Again, you don't have to by heart the whole thing. You imagine that there is a sac. Obviously, it is a sac, right? There is a sac and it is filled overly with fluid. What are the complications that can happen? There can be a premature rupture of membranes. When the membranes have been ruptured prematurely and all the fluid is rushing out, what can happen? Abruption of the placenta can happen. Because abruption has happened, she can have postpartum hemorrhage also. Because there is a lot of fluid for the baby to move around, malpresentations are common. And when the fluid comes out, the cord may jump out along with it, which is called the cord prolapse. So all these complications are more with polyhydramnios. Next question, again a question of polyhydramnios. 35 weeks of pregnancy with hydramnios and marked respiratory distress. How will you treat? By serial amniocentesis. That is how you can treat this. Now, which is the drug that can help in the treatment of polyhydramnios? The drug is indomethacin. Indomethacin is the drug, which is a prostaglandin synthase inhibitor, as you know. But will you give it? How long will you give it? Now, this cannot be given after 32 weeks, not given after 32 weeks. Why? What can it cause? It can lead to the premature closure of the ductus arteriosus. Okay, so that is about indomethacin. Next question. A 26-year-old priming gravida, 20 weeks, comes to the antenatal clinic for a routine checkup. She reports feeling well with no significant symptoms other than occasional mild dizziness when standing up quickly. Her vital signs are within normal limits. Her vitals are normal. Always look at that, her vitals. Vital signs are within normal limits with a blood pressure of 110/70 and a heart rate of 85 beats per minute. Physical examination reveals no abnormalities. Routine blood test shows a hemoglobin level of 10.5. What is her gestational age? She is 20 weeks. 10.5, which is a decrease from her pre-pregnancy level of 13.2. Which of the following best explains the decrease in hemoglobin observed in this patient? She is in the second trimester of pregnancy. Her HB is 10.5. You say that it is a decrease from a pre-pregnancy level of 13.2, but is 10.5 anemic in the second trimester? No. The cutoff for anemia in pregnancy is 11 in the first and third trimester and 10.5 in the second trimester. So she is not anemic. What is this? This is a physiological process, which is a hemodilution from the plasma volume expansion. Look at this. I'm sure you are familiar with this. See, all the physiological changes that are occurring in the hematological system in pregnancy are aimed at maximizing the oxygen consumption by the fetus. Alright, there is an increase in the RBC mass. There is also an increase in the blood volume. Okay, the RBC volume will increase by 20 to 30%. When does this start? Starts at 8 weeks. Starts at 8 weeks. But what happens to the blood volume? The blood volume increases by 30 to 60%. Since the plasma volume expands more than the RBC, there is a physiological hemodilution that is occurring. Why does this happen? Because the oxygen carrying capacity should increase. The hemoglobin mass and the oxygen carrying capacity of blood increases, but the hemoglobin concentration will fall in pregnancy. Okay, this is to ensure that the fetus is getting good oxygen. There is a fall in the hematocrit. There is also a fall in the viscosity of blood. All these are only physiological processes. This blood volume increases maximum when at 32 to 34 weeks. Okay. So here it is due to hemodilution occurring as a result of the plasma volume expansion. Coming to diagnosis, actually diagnosis is one of the most important topics in obstetrics, from where you'll get maximum number of questions. Okay, you may not be very familiar with diagnosis because I don't think you're doing scans or doing dopplers while you are in your undergraduate, but there are a few things that can easily help you arrive at your answer. That is more important for us, right? Let us take up the first question there. You have a 29-year-old woman, G2P1, presents to the antenatal clinic 32 weeks for a routine checkup. She has a history of well-controlled type 1 diabetes. Ultrasound reveals a fetus with an estimated weight in the 95th percentile for gestational age, consistent with macrosomia. The AFI is within normal limits. Doppler shows normal umbilical artery flow, but there is an increased PSV in the middle cerebral artery. This was supposed to be MCA, okay, not AAA. It is MCA in the middle cerebral artery. The increased PSV in the fetal middle cerebral artery is most likely indicative of which of the following conditions. Now, here, this question is a typical example of a question with a lot of distractors, things that can take you away from your answer, or things that can make you blind to what is important in the question, what has been mentioned importantly. So, you say that she has got a history of well-controlled type 1 diabetes, then you've got a fetus with macrosomia, and then they have mentioned the Dopplers. So when all these are mentioned, immediately your thoughts will go to diabetes and macrosomia, whether this has become a complication of that. But no, the only thing that is important in this question is an increased peak systolic velocity in the middle cerebral artery. That is the only take-home point from this question. You cannot study all the, because the speed of the middle blood flow through the middle cerebral artery changes with the period of gestation. You cannot study all that. One thing you have to remember, when the increased peak systolic velocity means the blood is flowing faster, there is a brain sparing effect that has occurred. Middle cerebral artery is a high resistance system where the blood flow is usually slower. But here, a brain sparing effect has occurred. They might also, even though you won't be able to remember all the velocities, you have to remember the multiples of median, as it is mentioned. If it is more than 1.5 or less than 1, more than 1.5 means the peak systolic velocity is higher. When is it higher? When the blood is flowing faster, when there is a brain sparing effect, which occurs in a case of fetal anemia. Here the answer is fetal anemia. So more than 1.5 multiples of median indicates fetal anemia, while less than 1, if the MOM is less than 1, that means there is fetal polycythemia. So these are the only 2 points you have to remember. In this question, what should your eye see? Only thing that should see must be the increased PSV in the middle cerebral artery. That is the only thing. Whenever you see that, your answer should be fetal anemia or something that has got to do with fetal anemia. You might get an RH incompatibility. See, if the choice does not mention fetal anemia, go for RH incompatibility, look for high drops, look for a parvovirus infection. See, all these things that can produce fetal anemia. It is nothing to do with diabetes at all. All right. So that is with that question. So if you're asked, what do you do when you find that the middle cerebral artery MOM is more than 1.5, then you have to go for a codosynthesis. You might need to do a fetal intrauterine transfusion. Okay. Next question. A 34-year-old multigravida, 30 weeks of gestation, presents with decreased fetal movements of the past few days. She has a history of chronic hypertension managed with labetalol. On physical examination, her BP is 160 over 100. Fetal ultrasound reveals an estimated fetal weight in the 10th centile for gestational age. Oligamnios with an AFI of 3 centimeters. Doppler studies showing absent end diastolic flow in the umbilical artery. MCA Doppler shows a low pulsatility index, and the ductus venosus Doppler shows a reversed A wave. What is the most appropriate management? Again, whenever Dopplers are given in the question, whatever else, whatever comorbidities have been mentioned, if Dopplers are given, immediately your attention should go to the Dopplers, what has been mentioned. They usually will never give a ductus venosus Doppler. Here they have mentioned a ductus venosus Doppler. Why did I say that they don't give? Because any change happening in the ductus venosus Doppler is a terminal event. You can expect an intrauterine fetal demise very soon. So, if they have mentioned something to do with the ductus venosus Doppler, look for an answer that is pointing towards a termination of pregnancy, irrespective of the gestational age. Here, what is the answer? You have to go for an immediate cesarean delivery. What was her gestational age? She said 30 weeks. So when you're looking at the next question, administration of corticosteroids, you know that corticosteroids are given for lung maturity till 34 weeks. But in this case, there is no time Why? Because there is already a change that has occurred in the ductus venosus Doppler. What about amnioinfusion or initiation of antihypertensive therapy? Because they have given a lot of distractors in the question, like in the previous one about hypertension and about low AFI. You might be tempted to pick that answer, but no, they have mentioned ductus venosus Doppler. There is a change in the ductus venosus Doppler. You don't have to think twice. Always go for whatever is helping for an immediate delivery, immediate termination of pregnancy, which here in this answer is immediate cesarean delivery. Next question. You have a 32-year-old woman, gravida 2 para 1 at let's say 32 weeks. Okay. At 32 weeks of gestation, presents to the antenatal clinic for a routine follow-up. She has a history of gestational diabetes, well controlled on diet. Her previous ultrasound at 30 weeks was unremarkable. During this visit, she reports decreased fetal movements over the past 2 days. NST is performed, followed by a biophysical profile. The BPP score is 6/10 with the ultrasound revealing decreased fetal movements, normal amniotic fluid volume and a normal fetal heart rate pattern. The image provided shows an ultrasound of the fetal abdomen with the umbilical artery Doppler waveform. So this they have given. The only Doppler that you need to know or you need to identify is the umbilical artery Doppler waveform. Others you won't be able to. Here, this umbilical artery Doppler, you find that there is an absence of the end diastolic flow. Normally, this is how you would expect the umbilical artery Doppler to look like. Okay. Here you find that this part is not there. It was supposed to go like that. So there is an absence of the end diastolic flow in the umbilical artery. Another thing that can occur is there can be a reversal of the end diastolic flow like this. It can either be AEDF or REDF. What do you do? When you're doing a Doppler, there are all three systems are being looked up. That is the maternal, where you look for the uterine arteries, the placental, which is the umbilical artery, and the fetal, which is the MCA. And after all these, we'll look for the ductus venosus, again a fetal system. So, umbilical artery, if there is a change in the umbilical artery, it indicates a circulatory compromise. That is, there is something wrong with the placental function. So we know that I said before the umbilical artery is a low resistance system and it is characterized by a forward low resistance flow. If there is a normal Doppler, you always remember, if they have mentioned that the Dopplers are normal, then it is reassuring. For how long? Reassuring for 1 week. If there is an absence of the umbilical artery Doppler, AEDF, as in this case, then the woman has crossed 34 weeks, what do? Then you can deliver her. If there is a reversal of flow, reversal of the end diastolic flow means it is tending towards fetal demise in around 1 to 2 days. So, irrespective of the gestational age, you will go ahead and deliver the woman. So, here, she's 32 weeks. There is an absence of the end diastolic flow. What do you want to do? You would like to take her up to 34 weeks, right? So, we'll administer the corticosteroids and closely monitor her. Instead of absent flow, if they had shown a reversal, that is, if there was something like this, then you wouldn't have waited. You would have gone for an immediate delivery. Okay. Coming to our next question, there is a 27-year-old woman. She is a G2P1 at 39 weeks. She presents to the labor ward with complaints of reduced fetal movements over the past 12 hours. No contractions, no vaginal bleeding or leakage of fluid. On examination, her vitals are stable and the uterus is appropriately sized for her gestational age. NST is performed, shows a baseline fetal heart rate of 120, minimal variability, no accelerations or decelerations over a 20-minute period. They have shown the NST also. What is the appropriate next step? Now here we'll just go through the NST. You know, you have all seen NSTs. It is the most commonly performed antenatal test, especially when she is crossed 32 to 34 weeks. What are the features that you see on NST, or how do you define an NST? An NST is defined as either it can be reactive, it can be suspicious, or it is non-reactive. If the NST is reactive, that means there must be variability, there must be accelerations, there must not be any decelerations, right? What is variability? Variability is the most important factor that determines the fetal outcome. The normal variability is around 5 to 25 beats per minute. Then you've got acceleration. Acceleration means more than 15 beats per minute or lasting more than 15 seconds. And there must not be any decelerations. Right. So that is how you define an NST. NST indicates that if the NST is normal, it indicates that the neurohormonal status and the cardiovascular activity of this baby is normal. That is the importance of NST. So here we have got one, a woman is presenting with the decreased fetal movements, and when you take an NST, you find that there is minimal variability. Why is the variability minimal? There is something is wrong. The baby has got some kind of a distress, right? If the baby had an active distress, he would have shown decelerations. Okay, decelerations also will come to. We'll just discuss that one also. There are three kinds of deceleration. First one is the early deceleration. Early deceleration, which occurs when occurs due to as a result of a head compression. Early decelerations. Then you have got variable deceleration, which occurs due to umbilical cord compression, and late decelerations, which is probably due to placental insufficiency. Of these three, the most important one is the late deceleration that occurs after the peak of the contractions. If you see an NST with a late deceleration, what is your management? You must take some kind of an emergency action. If she is on Pitocin, on oxytocin, you have to stop that. You might have to start IV fluids. You might have to change the position of the woman. While if it is an early deceleration, you can just wait and watch because it may be due to the descent of the fetal head. All right. So that is with regard to the decelerations. Here she has come with decreased fetal movements. How do you manage a woman who has come with decreased fetal movements and minimal variability? Whenever you have a woman who is presenting with decreased fetal movements, she has come with decreased fetal movements. What is the next thing that you do? The next thing that you do is you will perform an NST. And in the NST, what are the things that you will be looking for? You find the NST is reactive. You can reassure her and then you can repeat it after 1 week. Or twice weekly, depending on the risk. That is, whether this woman is hypertensive, whether this woman is diabetic, depending on the risk, you can repeat it either weekly or twice weekly. If the NST is suspicious, that is, there are no decelerations, but there are no accelerations either. And she has less than 2 accelerations, okay, but there are no decelerations. Then you can repeat the NST for 20 minutes. If it is still the same, that is when, if after this you find that it is reactive, you can again, just like before, you can either repeat it weekly or twice weekly. Still you find that this is not that good, then you'll have to go for a biophysical scoring. If the NST is pathological, then you don't, or that is, it's got a persistent late deceleration or variable deceleration, then you'll have to deliver her. What if she has got no accelerations, no decelerations, and no variability? In that case also, as in this case, there is no variability. She presents with decreased movements, no acceleration, no deceleration, no variability. The next thing you have to do is a biophysical scoring. So a biophysical profile, here the answer is a biophysical profile. A biophysical profile, it is also known as a Manning score. What are the components of the Manning score? You have the mnemonic, it is Batman. That is Batman, where you have got the breathing movements. Breathing movements, you have got the amniotic fluid volume, you have got the tone of the fetus. Then you have the movement of the fetus and the NST. These are the components of the biophysical profile. What are the indications? What are the indications? Where all do you do a biophysical scoring? If there is a non-reactive NST, as in this case, or it is a high-risk pregnancy. Here, Except for the amniotic fluid volume, all the others are indicative of the acute state of the fetus. The amniotic fluid volume alone is indicative of the chronic state of the fetus. Okay, so it is one of the most important things in the biophysical profile. NST is the first marker that is affected. This one also you have to know. Now, this takes around, doing a full biophysical scoring will take around 30 to 45 minutes. So, instead of a full biophysical score, you can also do what is called a modified biophysical profile. A modified biophysical profile means you do only two parameters. One is from the acute state and the other is from the chronic state. So, what are the things that you do? You'll do an NST and you'll do an amniotic fluid volume. That is, this will take only around 10 minutes time, right? If this is normal, that is the NST is reactive and the AFI is more than 5, then you don't have to worry. You can repeat the biophysical scoring after 1 week or so. But if any one parameter is abnormal, you will have to go ahead and do a full biophysical scoring. Okay, is that clear? That is with regard to NST and the biophysical scoring. Next question. We have a 35-year-old woman, G2P1, presents for her second trimester screening at 18 weeks. She underwent a quadruple screen which showed an elevated maternal serum alpha fetoprotein level. Her previous pregnancy was uneventful and she has no significant past medical history. An ultrasound is performed to assess the fetus. Which of the following conditions is most likely associated with an elevated maternal serum alpha fetoprotein levels? Aneuploidy screening has recently become a favorite with the examiners. That is why it is important, why I've added this question. So, what is maternal serum alpha fetoprotein? This is a glycoprotein from which diffuses across the maternal serum, diffuse across the fetal membranes and is seen in the maternal serum from around 12 weeks. And the maximum amount is seen at MSAFP is maximum at 28 to 32 weeks. Since this occurs as a result of diffusion, this is seen in high quantities if there is an open fetal ventral wall defect or if there is a neural tube defect. That is when MSAFP is high. See, a neural tube defect or an abdominal wall defect, you find that the MSAFP is high. What are the neural tube defects that you can see? As in the case of, say, for example, spina bifida, or a ventral wall defect like gastroschisis or an omphalocele. These are the conditions where you can see a high level of MSAFP. What else are there? What are the other markers or what are the other aneuploidy screenings? The first one, which we start in the first trimester itself, the T1, the first trimester screening, the most powerful marker in the first trimester is the nuchal translucency. This is the most powerful marker of aneuploidy. The nuchal translucency, if it is 3 millimeters or more, that means you'll have to do a further testing, like a non-invasive test, like looking for a cell-free fetal DNA or an amniocentesis. Okay, then you have got a double marker screening that is associated with this. There are two things that are looked for in the double marker: the first trimester screening or the double marker. Which are the analytes that are looked for? These are beta HCG and PAP-A. Where if it is a case of Down syndrome, that is trisomy 21, you find that beta HCG is elevated, PAP-A is reduced. While in the case of, see, it is mentioned here in trisomy 18 and also in trisomy 13, you find that both are, whether if it is a trisomy 18 or 13, you find both are reduced. Okay, that is double marker. Now she has crossed first trimester, like here she's at 18 weeks. What are the tests that you do? 18, that is around 16 to 18 weeks, say. Now you can do either a triple marker or a quadruple marker. A triple marker will include HCG, AFP and unconjugated estriol. While a quadruple marker will include HCG, AFP, unconjugated estriol and inhibin A. Okay, in case of Down syndrome, again you find that HCG is elevated, inhibin is also elevated, while in trisomy 18 and 13 all the markers are reduced. Now, in this question, if the question said she has got an elevated maternal serum alpha fetoprotein, what is your next step? Instead of asking what is the cause, if the question had asked what is your next step, what would you say? Now, you already said where is this found to be high? In the case of a ventral wall defect or a neural tube defect. How will you know whether there is a ventral wall defect or a neural tube defect? So, increased AFP, your next step will be to go for an ultrasound examination. Remember this very carefully. Look at the question. If it says next step, go for an ultrasound examination. Next question. A 37-year-old woman, G3P2, presents at 16 weeks for counseling about genetic testing options due to her advanced maternal age. She has no family history of genetic disorders. She is concerned about the risk of chromosomal abnormalities. After discussing non-invasive and invasive testing options, she opts for amniocentesis. Procedure is performed without complications and a sample is sent for analysis. Which of the following is the primary purpose of performing amniocentesis in this patient? This patient, why is she doing this? She's doing because she has got an advanced maternal age. What is amniocentesis? Amniocentesis is done at around 15 to 20 weeks of gestation. You take either the amniocytes or the fibroblasts of the amniotic fluid and you look for sex-linked disorders. You can look for karyotyping. You can look for inborn errors of metabolism, or you can look for neural tube defects. You can also look for fetal lung maturity, that is by looking at the lecithin sphingomyelin ratio. You can look for RH isoimmunization. So many things are there that you can look for in amniocentesis. But here, in this, the question clearly says what is the purpose in this patient? Why has she done this? Because of her advanced maternal age. So what do you want to do? You need to diagnose chromosomal abnormalities like Down syndrome.